Welcome to our second longevity event. My name's Carl and I'm a proud committee member here, and we're running these events as Together Tuesdays. Tuesday because it's going to be the first Tuesday of every month, thus today, and togetherness because it's so important to bring family, friends and community together for a happy long life. So one of the most important things of these events is to be the social and to come together as a community and to share and to support each other on that path. So they've been designed of these Together Tuesdays to be informative, practical, fun and social. And areas that we'll be covering will be like having a sleep doctor, fitness people, nutritionists, mind coaches, right across the gamut. And so for example, next month we've actually got someone from Technic Gym. For those that don't know Technic Gym, they are one of the largest suppliers of gym and wellness machines. And but before I introduce the speaker for tonight, I'd like everyone to get up on their feet on this very wet day. Yes. And I want you to go, and as we're doing a heartfelt evening tonight, I want you to go and introduce yourself to someone that you didn't come with and someone that you don't know, and share a very heartfelt story about yourself with them. So I'm actually very excited and proud for us to actually be hosting Natalie Raffel, who is from the National Health Foundation. She is a leading speaker on cardiovascular disease prevention. So her work very much focuses on design, building, and really expanding national health programs about preventative medicine and management from both a national and also a health perspective. So without further ado, I'd like to introduce you to Natalie.
So much, everyone. It's a real pleasure to be here, and Carl, thank you for coordinating everything so beautifully and smoothly for me to be here today. I'm actually really excited about this talk, and I'm hoping that it's a good blend of some information that you'll receive on slides. There'll be some graphics, some figures, but also we'll get some time at the end to do some Q&A, which I'm really excited for because really I just want to answer your questions. As Carl said, I currently head up the healthcare programs at the National Heart Foundation of Australia, and our programs reach across the country, and they span from running campaigns, mass media marketing campaigns, through to supporting people after they've been diagnosed with heart disease. I'm a clinical pharmacist by background. I specialised in cardiology, most recently working at Royal North Shore Hospital, and very much miss working in the hospital. That's why I love these sessions, because you can ask me individual questions. But now I'm really excited to say that the team have done a lot of work in pursuing the prevention of heart disease, so improving early detection and prevention of this condition, as well as supporting people to live longer and happier with heart disease. So today, I guess the premise of my talk is 8 facts that I'd like to share with you about heart health. They kind of span across different topics, different areas of heart health that I think you might be interested in, but there'll be plenty of time at the end for questions, and we'll hopefully cover more and more. I believe we are going to split up the talk with a bit of interactive little sessions that Carl will help us out with, but absolutely open to receiving questions throughout, or if you want to hold on to them to the end, that might be better. I'd love to talk about ways that you can personally better understand your risk of developing heart disease, yourself, your family, your friends, but also the actionable steps that you can take to improve your heart health and hopefully live long and happy lives. We have a lot of resources at the Heart Foundation as well, so I'll share that along the way. I guess before I start with my facts, we'll start number 1 with a few basics around the condition we are talking about today. Heart disease, or coronary heart disease more specifically, remains Australia's single leading cause of death. Absolutely, it is so for men, but overall in the population it remains our single leading cause of death. And that has a heavy burden not only on our communities, our health system, financially it has a huge burden, but also there's 51 people that lose their lives to coronary heart disease every single day, and their families will never be the same. So it's a huge health issue and priority for Australia. And I put this figure in because I thought it would be interesting actually to show you what heart disease death rates look like over the last, I think it's six or so decades, perhaps a bit more than that. And how there was a growing burden and a growing number of cardiovascular deaths or cardiovascular related deaths over time in Australia, and that was largely due to tobacco smoking on the rise, but also lifestyle and the lack of evidence-based and effective treatments to manage heart disease. And you can see, and you don't have to read the individuals, but there were big things like tobacco policy that came out, new blood pressure and cholesterol treatments, stents and open heart surgery procedures advanced, and all of this helped actually bring our mortality rate down, which is great. And now we're facing a low level of cardiovascular mortality overall when you look back. However, it still remains our single leading cause of death, so there's a lot of work to do. A few definitional things, and I hope to talk about all sorts of different types of heart conditions today, but cardiovascular disease is the broad terminology or umbrella term that captures all the types of heart conditions, and in fact it's so broad it also captures stroke. Under cardiovascular disease is coronary heart disease, which is characterized as heart attacks and chest pain. This is also the most common type of heart condition in Australia. Anything to do with blockages, and you've got my easy interpretation of the conditions underneath. The pipes leading to the heart are blocked. There's a blockage in there somewhere, and that's leading to coronary heart disease. Heart failure is where the heart ventricles in particular, so the bottom two chambers of the heart, are not pumping as they should. So this is a pumping issue. Our pump is not working as well as it should. There are rhythm disorders. There's a whole host of rhythm disorders, and that's an electrical issue. So again, another type of issue, either that your electrical system in your heart is misfiring or not firing enough. Peripheral vascular disease has more to do with blockages around the body, so in the extremities of the body, your arms and your legs, but again, often has to do with blockages in those veins or arteries. Heart valve disease is essentially where the valves in your heart, which are just those doors that open at different chamber connection points in your heart, are faulty. They're not working as they should again, and then that causes blood to back up or pool in different areas where it shouldn't. Congenital heart disease is a deformity or abnormality in your heart that you're often born with. And this is a structural problem, so structurally something's wrong with your heart. And stroke, well, they have a whole foundation, so you can talk to the stroke foundation, but that is essentially where there is a blockage to oxygen to your brain, and that can be either caused by a blockage in the arteries, by fatty plaque buildup, or bleeding in the brain that causes that oxygen to the supply to shut off. So we're on the same page, hopefully. When I say heart disease today, I'm probably going to refer to coronary heart disease, remembering that's heart attacks and chest pain in the first most popular area. However, if I mention any others, I'll be really specific. Back to human anatomy, I won't dwell on this for too long because you probably already know this, but the heart's a pump. It's a simple organ, yet essential. It will beat thousands of times by the time this talk and your drinks are finished at the end of tonight. And it essentially has a really critical job, taking oxygen-rich blood to the different parts of your body, especially your organs, in order for them to continue functioning as they should. It then recycles the deoxygenated blood, the blood that is full of waste and has been sucked of its oxygen by your organs, takes that to the lungs, and that's the blue going to the lungs, and it is reoxygenated through the lungs and comes back as red oxygen-rich blood that goes off to the rest of the body. So that's essentially how it works. But I guess really importantly, while your heart is sending oxygen-rich blood to the rest of your body, it also needs its own oxygen. Otherwise, how is it going to function as an organ? And the arteries that are sitting on the outside of the heart, and you can see them in what is the arrow that's pointing on the outside. They are known as coronary arteries. They're quite small, but they're very, very important because they feed your heart with oxygen. And if they get blocked, your heart muscle dies. It dies off. And the longer they are blocked for, the more muscle that you will lose in that. And unfortunately, sometimes if the oxygen supply has been cut off for long enough, that causes a heart attack, which may cause death if you do not get immediate attention to reverse that blockage. So what builds up on the inside of these coronary arteries? Well, we call it fatty plaque deposit, but really it's just cholesterol-rich deposits that stick to the inside of your arteries and harden over time to make a plaque, as they call it. And the plaque itself is actually not the biggest concern. The plaque sits there on the inside of your arteries, and it accumulates and accumulates over time. And in fact, a 14-year-old will have evidence of plaque deposits in their arteries. So everybody has these things. Some people get them faster than others, or you will have accelerated growth of the plaques in your coronary arteries. And I'm going to talk to you about what can accelerate that plaque buildup in a moment. But what happens is that if that plaque is unstable and it bursts, and I think the image you can see at the bottom, it's sort of just bursted, there's a hole in that yellow plaque, then your body says, oh no, there's a burst artery. It thinks that your artery is burst open, so it sends over a clot, it sends the platelets, and it actually starts to block up both your plaque and your entire artery, causing a blockage of oxygen to your heart. And initially, that's chest pain. You will feel chest pain. If that blockage goes all the way and there's no blood that is flowing through that artery anymore, that is a heart attack. And as I said, the more time without oxygen, the more muscle in your heart that will die. So time is muscle. Gladly, there's plenty we can do about that, and I'll talk to you more about risk factors in a moment. But I thought I'd start with fact number one, because this is a big misconception I get a lot, and sometimes even in movies I see it really not done very well. And that is that a heart attack and cardiac arrest are very different things. And sometimes they are connected in that sometimes one can lead to the other, but they are different things and they are caused by different things. So a heart attack is what I just described, and I put Shane Warne there because he is probably one of the most famous Australians to have had quite a massive heart attack and unfortunately took his life. And it is caused by blockages of those coronary arteries, which I just explained. When you're having a heart attack, often you will have symptoms or warning signs, including chest pain, but that's not the only symptom. We'll go through the rest in a moment. But you're often conscious and you can often feel it. You may then go on to lose consciousness and have a cardiac arrest. However, you can have a cardiac arrest without having a heart attack. They are different things. Cardiac arrest is when the electrical system in your heart suddenly switches off. It's like switching off the power in a room. So it's on, then it's off. And that's why, sadly, a lot of people that experience a cardiac arrest don't have any symptoms. They don't have any warning signs. They just suddenly their heart stops beating, and they will have they won't be breathing. They won't have a pulse, and it can be caused by a whole host of different things. It can be caused by trauma. It can be caused by a rhythm disorder, a congenital condition that you're born with, or even a really big heart attack can put your heart into shock and create cardiac arrest. I guess essentially in both of these cases, it's really important to know you call 000. That's really important, call 000. But we'll get to that in a moment. But also you do a few things after that. And I thought maybe we could make this a little bit interactive, and I'll hand over to Carl now to do a bit of the quiz maybe.
So what should you do after calling 000? So there are 4 options, A, B, C, and D. So you think, with a show of hands, who feels that you should elevate their legs to improve the blood flow to the heart? Any takers for that one? 1, 2, 2.5, 3. Alrighty. So how about we roll them into the recovery position on their sides? We have one, half a one, 2 halves, 3 halves. Alrighty. Drive to the closest AED, which actually, does anyone know, just to promote it for RACA, does anyone know where this is on RACA? And maybe our president knows? Our president, David Maloney?
Next to the lift well.
On what level?
2.
Level 2. So should you get the lift down to level 2? What's AED?
It's a defibrillator, automated defibrillator.
So does anyone think that would go down to level 2? David would take you personally?
Yeah.
Yep.
Yeah. I changed my answer.
Change your answer, 4, 5. The final one is giving 30 compressions followed by 2 breaths and repeat. So we've got 2 of this, which I was actually going to get Natalie to do an example of this. But does anyone want to know what happens if you do an example of this? Obviously, this is why I don't run these events. What happens if we did an example of this, Natalie?
I will probably break your ribs. And that's quite normal when you're doing CPR. If you're doing it properly and for long enough, you may actually break their ribs.
Alrighty, so Drum, what is the answer?
The answer is the last one. Yeah, so that is start administering CPR right away. I guess in this we've created a bit of a trick alternative here because your AED is on level 2. So if we were all in the room and I suddenly dropped, somebody start CPR. First, somebody call 000. Somebody start CPR and send somebody to level 2 and come back. But do not drag this person, if you were alone with them, into your car, drive them to an AED. You're wasting precious time. You should start administering CPR straight away. If somebody else is available to find you a really close AED, that's great. But yeah, you start doing them. In terms of how fast, I often get that question, how fast do you do AED? So, to do a CPR, hands across over each other like this, you find the center of the sternum, which is that middle bone in the middle. And for a woman, I will flag, that is an awkward position. It's almost the middle of their bra. And often we find that women aren't administered CPR as much as men because it's a little bit embarrassing or like you just don't know what to do. You're saving their life, do it. It's in the middle there. And so hand over hand, and then start with the compressions because there's a little bit of oxygen already in the blood. So often people go, do I start with breathing or just start with the compressions? 30 compressions. You can do it in terms of how fast you do them. If you know that song, Staying Alive, it's a little bit old. I don't even know who sings it, but that song, if you do it to that rhythm, then yeah, that if you sing that while you do it, that's exactly how fast you should be doing CPR. And then 2 breaths, and then keep going. CPR is very hard. It's intensive, and it's not over after a 30-second period. So be prepared to go for a few minutes and then switch around with somebody else so that you can continue to administer that until the emergency arrive. And they'll also be on the phone with you so they can give you some instructions on what to do.
Sorry, do you have the same question for a heart attack?
So for a heart attack, they're conscious often. They're not. They haven't lost consciousness. They are still breathing. They are often in pain, nauseous. They're weak, and so you wouldn't administer CPR.
What's the right answer? Because I'd heard a low dose aspirin is a great idea, and then get them to hospital or get the ambulance. What do you
Yeah, it's a good call, and you are very right. The guidelines for a very long time included advice about giving 100 milligrams of aspirin. Right now, the recommendation has changed, and we've dropped the aspirin recommendation only because, look, there's a lot that could be done as soon as they reach hospital, and often they load them with a lot more than 100 milligrams of aspirin to thin their blood, so there's not that much to gain out of giving it to them before they leave the house. Continue to monitor them. Call 000. Ambulance is the first call if you can access that, and just continue to monitor them.
And Natalie, can you just give an example of the 2 breaths or describe
what you would do to do so you would just pinch their nose, hold their nose, open their mouth, hold them on the floor, and then breathe in 2 times. So you can breathe 1 breath, close, 1 breath, just 2.
Thank you.
No worries. Yes.
Let me ask you, what is the difference in terms of the action between like C and D? As in, for example, if you have someone who is experienced with CPR, and also if you have a defibrillator right next to you, which one which excellent?
It's a very good question, and it's an easy one. The AED wins every time.
Yeah.
Yes, the AED wins every time. The survival rate after you have a cardiac arrest is very low. I mean, 5% might survive out of hospital. That bumps up to, maybe we can double or triple that with an AED. But getting them, to help after that is also really essential. But the AED is a defibrillator, so it actually delivers an electric shock to the heart. Unlike what some people think as well, it will never give the shock if it's not safe to do so. So that's what some people tell me. I don't want to give them the shock. Maybe I was wrong about them being in cardiac arrest, or maybe it will do more harm. It won't. It actually knows. It's really smart. So it will shock when it's needed to be shocked, and it won't when it won't. And it also just gives you all the instructions. So if you never use one, you just open it up and it tells you to do everything. Open open their t-shirt, or use the scissors to cut it open, put the pads on, step away, press this button. That's it. Yeah. Very.
Thinking that in an emergency situation, you're more likely to be able to do CPR because you kind of instinctively know what to do.
Yeah.
Whereas if you have to figure out how to use an AED and do this and do that, you might lose time doing that.
It is a good point, and I think there's no wrong or right answer. I mean, if you started, that would be great. If you had access to an AED, so bringing that over, or it was close by. Like I said, the AED wins over CPR though. So even if you lost a bit of time trying to fiddle with it, open it up, get it going, you would still gain more in the long run because it's giving the electrical current directly. Whereas what you're relying on with the compressions is you're essentially massaging the heart from the outside. You might break a few ribs as you go in there to shock it back awake. So it's not as effective as delivering natural electrical current. Yeah. Anyway, well, I wish I had brought a mannequin. I'm sorry. I'm sorry you couldn't get the live demo. But the Heart Foundation does a lot of work in this space. We have recently teamed up with Greg Page, the ex-Yellow Wiggle, and his organisation called Heart of the Nation, which really was all about raising awareness for cardiac arrest and what to do in that situation. And he's done a great job, so we're really excited to be working with him to roll out future campaigns. And it's really great to see that you've got one here, and I saw the signs and posters for it as well, which is really great. So more awareness, the better around your AED. So now let's go back to the heart attack for a second. Someone's having a heart attack, and I love that question. What do? We call 000 immediately. That's the right answer all the time. But it's really important to know that not everybody will experience the most typical symptoms of a heart attack. Chest pain is the most common symptom of a heart attack in both men and women. That's for sure. We know that. We've seen it on TV. Everyone's clutching their chest. But there may be other symptoms that are a little bit more subtle. Things like nausea or feeling like you're going to vomit, being lightheaded, dizzy or fainting, feeling generally very weak or fatigued, feeling cold shivers, or feeling like you've almost got a bit of a temperature but you don't. So that's how people have described it. And people can also feel short of breath. They can't catch their breath properly. And it's important to point out that women are more likely than men to experience non-chest pain symptoms of a heart attack. Chest pain is still the most common symptom in a woman, but they're also more likely to have these other symptoms than men. And I think I'd also call out a much smaller group of people that are living with diabetes, or in fact older people that are prone to have silent heart attacks. Far less common than your everyday heart attack. Probably about 5 to 15% is the latest estimate, but these are heart attacks that you don't really feel anything with. You might feel a bit off, or there's no real obvious chest pain associated with it. So that's another thing to consider. I'll also flag that no two heart attacks are the same, even in the same person. You can have a heart attack a year ago, you could have had one, and then you can have one in 5 years and they could feel very different, which is a bit annoying because then you thought you know what it felt like, and it might change. It all has to do with what part of the heart is blocked in that coronary artery complex system on the outside of the heart. So that's why it's different. So we'll move on to the next thing. So we've discussed heart attacks, we've discussed warning signs. now let's talk about some of the risk factors that lead into heart attacks. And I kind of thought this was obvious, but our research shows that not a lot of people know that high blood pressure and in fact high cholesterol, which I'll talk to in a moment, are two of the leading risk factors for heart disease. They are very much connected. Living with high blood pressure is only a problem because it leads to heart disease, or in this case, heart attacks and strokes. It also can damage a lot of other organs, your vision, your kidneys, even your liver, and lead to other peripheral vasculature blockages as well. So I just wanted to kind of call that out. It's very common. Unfortunately, about 7 million people in Australia are living with high blood pressure, and about half of them don't know it. High blood pressure is what we call a silent killer, and that is not ideal. So I'll move over to the next quiz question.
So we're doing another fun quiz. This one's a numerical one. So what is a healthy blood pressure reading? So we'll start at the top, 100/50. No, we haven't got any takers to that. Pessimistic. How about 120/80? Okay, so most people, killed. 90 to 120. No. 12/9. Christian, was that you? No?
Yeah.
Our registered nurse? Exactly. So I think the group thinks it's 120/80.
Yes, that's correct. Well done. That's fantastic. Knowing your numbers is amazing, and the fact that you know what it should be is great. Now, if I ask you what your blood pressure is, will you be able to tell me as well? I hope so. So blood pressure is measured in two numbers, as you can see, the top number and the bottom number. It's essentially the pressure, or it measures the pressure that the blood exerts on the inside of your artery walls. And the top number is the pressure when your heart is beating, and the bottom number is when it is relaxed. So it's systolic blood pressure over diastolic blood pressure. And ideally it should be 120/80. One moment, and I'll just say, now more and more evidence is supporting even lower levels of blood pressure. So particularly for people that are at high risk of having a stroke, or that are younger and fitter and can handle slightly less blood pressure, we can go a little bit less than 120/80, which is good. High blood pressure, the diagnosis for that is from 140/90, and high blood pressure is not diagnosed as a once-off. It requires a number of different readings that your doctor will take. You might take in other settings, and they'll look at over time to make that formal diagnosis. Yeah, it's a good question. So the ideal healthy blood pressure range that I've put here especially is for the everyday person, the average person. If you have been diagnosed with high blood pressure, which means at one point your blood pressure was above 140/90, particularly if you're on medication or if you're on a treatment strategy, then the target for lowering your blood pressure, 130/80 is sort of 130/90 even is perfectly acceptable. And then your doctor, sitting in front of you, might decide different things for you. So like I said, if they're a bit younger, might try to push the blood pressure a bit further down. If they're particularly at high risk of stroke, you might again try to push it further down than 130, less than 130. If you're worried about this person falling over, if their blood pressure goes too low, then you might leave it at 130, or between 130 to 140. So it's a kind of a discussion that you have with your doctor.
There is a term, I think, is labile blood pressure. Labile blood pressure, which means that you can move around quite a lot, depending on anxiety or weight co-adolescence, it just fluctuates quite a lot.
Yeah,
labile, I think it's called.
Yeah. Look, I haven't heard that terminology, but you're very right in flagging that blood pressure changes over time, as in over your day, from whether you're waking up, whether you're eating, whether you're exercising, whether you're drinking coffee or otherwise. So it certainly fluctuates. There are a few phenomenons known as, one is white coat hypertension, where if you're sitting in front of a doctor or in a clinic, your blood pressure artificially elevates. And there's another one called masked hypertension, situation where the opposite happens. In front of your doctor, your blood pressure behaves, and then at home it's really high. So the way that we pick up on these kind of phenomena with your blood pressure is something called ambulatory blood pressure monitoring, where you wear the blood pressure cuff and the machine for 24 hours, and it monitors your blood pressure all throughout the day and night. So have you had the pleasure of wearing one? It's not very comfortable, but it's essential to diagnose, particularly for these kind of conditions. We at the Heart Foundation have a whole host of resources online to help you in measuring your own blood pressure. Does anyone have their own machine at home? Oh, fantastic, great. So you should be taking a look at your blood pressure as often as is sort of necessary. But we've got some great tips on how to do it. You know, sitting with your feet planted on the ground, your hands at sort of heart level or a little bit higher. Don't use the wrist cuffs, they're not approved or not validated. And so talk while you take your reading. Try to do it after you've eaten, not right at the point of when you've just eaten. And take 3 readings, discard the first one and take the average of the second 2, and that's your blood pressure reading. Most importantly, record it somewhere for your GP to have a look at. So the other second leading risk factor for heart disease, in fact, I would call this a cause of coronary blockages, and that is high cholesterol. A very contentious area, I'm not sure why. There's been a lot of history here though, and I'm really pleased to give you a little bit more information on high cholesterol because it's such an important issue. It's another one of those silent killers. We've got about 4 million Australians living with high cholesterol, and again, probably about half of them are unaware of it. High cholesterol is caused when, it's related to high levels of different types of cholesterol in your blood. So first things first, cholesterol means many different things. There are many types of cholesterol in your blood. Cholesterol is essential for the functioning of your body, including the production of hormones and the development of your cells and the functioning of your organs. But too much of cholesterol is not a good thing, because as I said to you, the inside of those coronary arteries get plugged up with fatty plaque cholesterol rich deposits, so they're directly related to your risk of having a heart attack or stroke in the future. It kind of depends which type of cholesterol is high. There are many types. I haven't covered nearly all of them. I've only covered 2, the most popular type here. LDL cholesterol, low density lipoprotein cholesterol, is the bad type. It's the sticky type. It goes and it finds the inside of your coronary arteries and it deposits there to create those fatty plaques and cause heart attacks and strokes in the future. Ideally, we want this to be less than 3.5, but I just want to flag that's for the average Australian. If you've been diagnosed with high cholesterol, or if you're at high risk of having a heart attack, or if you've had a heart attack in the past, we want that LDL cholesterol to be a lot lower than 3.5. In fact, we probably want it to be less than 1.4. So it ranges, it's different for everyone, but if you're living healthy and you're sort of average, less than 3.5, otherwise even lower if you've got a heart disease or a high risk. The good type of cholesterol, high density lipoprotein cholesterol, is the kind that actually circulates in your blood, and it goes to those fatty plaque deposits and actually recycles the bad cholesterol back to the liver. So we want this to be high. This is the good type. And your next question is probably, what do I eat to lower my bad type and increase my good type? Well, I'll make one statement up front, and that is that food is only one way that your cholesterol is elevated in your body, i.e. your liver also produces cholesterol. So even if you ate the most perfect diet, some people can still have high cholesterol because their liver produces too much of it. And even if you had really high cholesterol and you ate the most perfect diet, you could reduce your cholesterol by 15 to 20%, which sometimes is not enough. So just flagging that high cholesterol is not always caused by bad diet. But there are some things we can do and change about our diet right now to make it, to lower it. And that includes things like staying away from all the yummy stuff rich in saturated fat. So that is the cheeses, the dairies, any processed junk food, pizzas, pastries, biscuits, red meats, unfortunately also quite high in saturated fat. Anything rich in saturated fat, reduce your bad cholesterol, and then we want to up the good cholesterol, the HDL cholesterol. So that's things rich in omega-3 fatty acids. You want to increase your fish intake, your vegetable intake, whole grain intake, and use the healthy types of fats like in avocados and nuts. Yes, nuts.
Yes, avocado, absolutely.
Avocado, yum. Yes, I know. It's a good excuse to eat avocado. The other one I love is, if you've been to grilled burgers, they're zucchini chips. Zucchinis are so healthy. They're beautiful. They're delicious. They're low calorie. They've got lots of nutrients in them. But they dip them in this batter and then fry them so that their calorie count is quadrupled. And the salt in it is also 100 times higher. So you just take this beautiful vegetable that was so healthy to begin with, and it's processed.
So it's not the innocent old potato, it's the junk.
That's it. Yeah, it's how it was made. You're exactly right. Salt is blood pressure. So too much salt in our diet, in particular, can lead to increased risk of having high blood pressure. So if you cut salt out, and in fact the Heart Foundation has just sponsored some research looking at switching salt with potassium-enriched salts, and that actually reduces blood pressure as well across the country. That's an interesting fact. And try to flavour your food with herbs and spices instead of salt. The complexity around diet is that it's firstly evidence with randomized controlled trial, high quality evidence is lacking in nutrition in general. And that's because it's firstly very hard to get people to stick to diets, but secondly also to blind them to what they're doing. So high quality evidence is
record what we eat. We
that's
record
right.
what we want to eat rather than what we actually put in.
Yeah, absolutely. So that's the first issue. But the second is also looking at the outcomes that you're sort of after. So there are different types of diets that might restrict calorie count, so energy, GI, absolutely, glycemic index I've seen. Then there's also diets that try to up one type of, eating pattern or style, the carnivore diet, for example. There's intermittent fasting, there's a whole host of different diets. The Heart Foundation did and I might just skip to it and then I'll come back to it, did a very specific evidence review and synthesis to look at what diet would help your heart health outcomes. And I just want to be really specific about that. This diet won't necessarily make you lose weight. That's not the diet for that, but it will just overall has been associated with less heart attacks and strokes. And so this is where, unfortunately glycemic index didn't come up as something in this evidence review, but we know it's linked to inflammation. We also know it's linked to diabetes, which is then also linked to heart disease. So it's sort of like right now we don't include it in our dietary pattern advice, but yeah, it's that next layer of connection, which is really important. So these are the heart healthy eating patterns. These are if you ate these patterns in line with these patterns, and I hope this was in line with our last talk, you would protect your heart. And that it's really obvious stuff. Plenty of vegetables and fruits, lots of whole grains, a variety of healthy proteins, particularly fish, unflavored milk, yogurt, and cheeses. And if you have high cholesterol or have heart disease, opt for the low-fat variant of these dairy products. Healthy oils and fats, as we discussed, and try to limit your salt intake in your diet. That would improve your heart health outcomes. Weight loss is a completely different story, I think, and although there are many of these elements that overlap, there's a complexity to that the Heart Foundation hasn't started to tackle yet, but we're really excited about it because we're moving into the obesity space now as one of the leading risk factors contributing to heart disease. So yeah, it's really important. Yeah, I wanted to talk about statins for a little bit. I mean, obviously I'm a pharmacist, so this is of interest to me, but also we continue to have a lot of reluctance around statin medication and their use. And I guess a few things I wanted to say. Number one, statins are used when they need to be. We don't use statins unless you need them. And that comes back to what I said earlier around, even if you had really high cholesterol, even if you have the most perfect diet, you could only reduce your cholesterol by 15 to 20%. So sometimes we call in backup, and in this case the backup is statin medicines. They are among, if not the most studied medicines in our history, with over 200,000 patient data worth of randomized controlled trial data to inform their use. So they're very, very well studied, and that they are. It also means we know a lot about their side effect profile. So some people, a small group, will experience muscle-associated side effects to do with statins, and in the large majority, I actually wrote the algorithm to treat these muscle symptoms. In the large majority of these people, 80 to 90% of them, you can resolve that temporary muscle soreness by halving the dose or switching to another statin. So there's a lot of things we can do to manage those side effects, and in people that need them, they bring on more benefit in preventing your heart attack by lowering your cholesterol than they do any harm. Statin medicines for people that are at high risk, especially if you've had a heart attack, cut your future heart attack or stroke risk by up to 30%. There's a huge benefit from being on these medicines, particularly if you've had an event. You're the highest risk people. Not only does it reduce your cholesterol in that setting, but it also reduces inflammation in the arteries. You're absolutely correct in saying that with a statin medication, an individual statin, say Crestor or Lipitor, whatever it may be, if you double the dose, you don't get much more benefit. The most benefit that comes from a statin actually comes from the middle dose. So if your cholesterol is very high, you're actually better off adding ezetimibe in addition to a moderately dosed statin rather than doubling the dose.
Well, I did the reverse. I reduced my statin by half.
Well, that's
I was on a modest
especially if you're
dose. Now I'm on
having
a tiny
symptoms.
dose.
Yeah.
And I'm getting the better impact for less potential downside.
It's a possibility, and it's definitely something you can discuss with your doctors. Where maybe the Heart Foundation is not supportive, only because the evidence is not there, is CoQ10 and glycanol, or sorry, I can't pronounce it either. Unfortunately, although metabolically and scientifically the mechanism is there, the evidence has not shown long-term benefits. But perhaps the higher quality studies are more necessary. Actually, we don't really use statins only for high LDL anymore. We used to. That was the old way of doing it. So doctors would look at your LDL. If it was high, here's a statin buy. Now we actually look at your overall risk, and that's when a statin is prescribed. So it's actually more important to know what your overall risk of developing cardiovascular disease is, with all your risk factors, including your LDL or your total cholesterol and HDL, and then making an assessment as to whether a statin would be relevant. And I'll show you in a second, because I think it's actually really relevant. So firstly, flagging that family history is a strong predictor, and I might just get to that slide because I feel like we're getting to it, and it's so important. It's the premise of really why I'm here, to talk to you about overall your risk of developing heart disease. And some people think it's just one thing, and I've talked to you about cholesterol and high blood pressure, and if you look at one of the each of those things in isolation, you might say that one's okay, or that one's a little bit off, what do I do? The reality is that all of these risk factors combine in a non-linear way to increase your own chances of having a heart attack or stroke in the immediate future. The way they combine is complex, and we don't have it perfect, I'll admit that, but we have some pretty fancy algorithms, prediction algorithms known as multivariate algorithms, that help us get closer to predicting how these things influence your own chances of developing heart disease. Family history or genetics is a really tricky one, and that's because people don't know their family history very well. Or like if you ask me, my great-grandmother died, I don't know how she died, I have no idea. So it gets really complicated, and I think what I would say is that family history warrants, particularly if it's premature family history, warrants earlier screening and detection. And that might be more than just what's your blood pressure and cholesterol. It might be imaging as well that you might require from your doctor, and it's a conversation you have with them. But family history of premature heart disease means in a first degree relative that is a male who had heart disease younger than 55, or a female younger than 65. In a first degree relative, that is a family history of premature heart disease, and that one it does increase your own chances of having a heart attack in the future. Some risk factors you can't really do much about: your age, your ethnicity. We know that South Asians, Pacific Islander, and some Middle Eastern populations have a higher rate of cardiovascular disease compared to others. We also know that some South Asians have a lower risk compared to others, and of course Aboriginal and Torres Strait Islander peoples have twice the rate, if not higher, of cardiovascular disease compared to non-Indigenous Australians. So ethnicity matters, sadly. Gender matters in that there are a higher number of men that develop cardiovascular disease each year compared to women, but also men develop their cardiovascular disease earlier on in life. Women often experience cardiovascular disease after they've hit menopause, or a higher rate of heart disease after menopause when the protective effect of estrogen goes away. And family history we've discussed. The good news is there's plenty we can do about our heart disease risk, the things we can change, whether we smoke or not. Smoking is the biggest risk factor for heart disease. If you want to cut your heart disease risk in half, stop smoking. That's the key risk factor. Cholesterol we've spoken about, blood pressure we've spoken about, diabetes and how well you control your blood sugar level also can improve your heart health. So if you have diabetes, keeping a good tight control of your sugar levels helps your heart. Being physically inactive is a risk factor, and moving more as much as possible is what's recommended by the Heart Foundation. And of course, we've spoken about diet as well. The Heart Foundation is particularly encouraging people from the age of 45 or earlier, if you have a family history, or if you have diabetes, or if you are of First Nations descent, to see their GP for a Medicare subsidised heart health check. And this is where it's kind of the first stage of assessment, where the GP takes all your information about your medical history, your family history. They'll check your blood pressure, your cholesterol, your blood sugar levels, and then they'll use this really cool, if I must say so myself, predictive algorithm that the Heart Foundation have developed to help estimate somebody's probability of having a heart attack or stroke in the next 5 years. It's called the Australian Cardiovascular Risk Calculator. It's online. It's been used now 1.3 million times by GPs across the country since it launched, and it is the most robust and best available evidence to help support how you predict your risk of having a heart attack. And the doctor does it because there's some clinical risk factors in there that they need to help you with, but most importantly, the GP then will work with you to lower that risk. So in your case, they will look at your cholesterol, but that's not the only thing they'll look at. They'll look at your blood pressure, your age, they'll look at your family history, they'll look at whether you have diabetes or not, and whether that's controlled, your postcode, whether or not you have atrial fibrillation, for example, which is another heart condition, and then they'll estimate your risk, and then they'll decide whether or not to start a statin. If you are at high risk, then the guidelines recommend starting a cholesterol-lowering medication like a statin, as well as a blood pressure-lowering medication, such as perindopril or an ACE inhibitor. There are many available. The evidence shows that the benefit is only modest if you're not at high risk. So at an earlier age, particularly less than 45, age is a big driver of your risk, so you're unlikely to be at high risk. And then if you're sitting in a lower category, the data suggests that statins are less effective. And so in terms of benefit of cutting your heart and stroke risk in the future. And then you have to also weigh up, well, then you might have side effects. So is it worth taking the tablet every day if it's not giving you that much benefit? And then the other question is, can you cut saturated fat from your diet and take polysterol, enriched products to bring your cholesterol down enough? Does that work? And is that, like a first step? Oh, you're already doing that, are you? Fair enough. Anyway, it sounds like it's a very one-on-one conversation with your GP, but let them use this Oz CBD risk calculator to estimate your risk. I won't dwell on this, other than to say the Heart Foundation is doing a whole lot to encourage people to get these checks, and that is through campaigns. We're supporting GPs to do the clinical checks. We developed the guidelines and the calculator for them to do it, and we're also rolling out these sort of targeted screening programs via text messages across the country, and we have almost 1 million. We're going to hit 1 million by the end of the year, we're sure of it, heart health checks to live in Australia. There are some really fantastic advanced and effective treatments for heart disease, or heart attacks in particular, blockages in those coronary arteries that range from ballooning the inside of the artery, stenching the inside of the artery, breaking down that blood clot if you're too far away from a hospital in rural or remote Australia, as well as open heart surgery, which I'm happy to take questions on if that's better. Last one is really just acknowledging that connection between mental health and cardiovascular or heart disease or heart health. There's sort of an interconnected relationship where having poor mental health, particularly severe mental illness or severe mental conditions, can increase your risk of developing heart disease, and the other way around, having heart disease can also increase your risk of having mental health conditions conditions, or particularly anxiety and depression. Cardiac blues are quite temporary in the 2 to 3 months after your diagnosis, but they can last longer term for some people. So I'll stop there.
So firstly, with heart disease being largely preventable, what are the most significant lifestyle changes individuals can make to reduce their risk?
Yeah, if I had to rank them in order, cutting smoking is the top one. It's the easiest way to reduce your risk. Being more physically active, getting 30 minutes of exercise on most days of the week, and at least 2 sessions of strength training a week is beneficial. Eating a heart-healthy diet, which we discussed earlier, limiting your alcohol intake. 0 alcohol is the most healthy for your heart, however limiting it is beneficial, and keeping a close eye on your blood pressure, your cholesterol, and keeping track of them is really beneficial.
Another question is, could you share some of the National Heart Foundation's recent initiatives aimed at improving early detection and management of cardiovascular diseases?
Yeah, sure. We've got a few, and I had some on the slide, so I won't go into all of them in detail, but one that I think is probably has been the most impactful for us is introducing a targeted screening program in general practice or in medical centres across the country. We enlisted about 400 GP practices across the country to send a simple text message to their patients that were over 45 that hadn't had a heart health check recently, and ask them to come in for that 20-minute checkup. And we saw a 13-fold increase in people taking up the checks. And we hope to expand that further and seek government support to make this a little bit more formal for Australia.
Amazing, thank you. So, what are some emerging trends or research areas that cardiovascular health that you've particularly excited with you, that you've been excited about?
There's so many, I don't know where to start. I think if I had to rank them, the area of obesity and cardiovascular disease is exploding at the moment. I'm sure you've seen on the news every week there's a new weight loss medication cuts X, Y, and Z. But probably from a most impressive point of view, the Heart Foundation and cardiologists in general are really excited about the heart health outcomes that some of these weight loss medications have. And in particular, they are cutting your risk of a heart attack almost similar to a statin in people living with heart disease. So I'd say that's one huge area. We're getting better at imaging the inside of your heart, your arteries, and therefore predicting your risk. And so there are more and more technologies there to get us closer to predicting your heart attack even better. And there are also some really cool genetic tests that are being, they're called polygenic risk scores that are being developed that can take your genes and assess your risk of developing heart disease in the future. So those are just some.
Cool. Second last question from members was, for those that are looking to take immediate action steps, what are 3 practical steps, maybe you want to do one, that can be implemented today to improve their heart health?
It's a good question. I love the
Like
simplicity of it. Yeah, immediate. Yeah. Well, for those that had a blood pressure machine, go home and check your blood pressure. Start there. For those that maybe don't get more than about 3,000 steps a day, try to increase that by 1,000 steps next week if you can, on some days of the week. Or at the very least, stand up at least once every hour in the day to get yourself moving a little bit more. And the next time you go to eat a piece of dairy, might opt for a lower saturated variant of that dairy product, whatever it may be. We'll do that.
Final question, and Millie, this is my question, and from my friends, is how have all, we all wear wearable technology. A lot of us wear wearable technologies. Thank you, Bradley. iWatches, Pebbles, all the rest of it. So actually, what would you recommend these? How accurate are these? How much value should we put behind these?
Yeah, it's a good question, and there's more and more data emerging from wearables and what they can do and detect. So let's start with heart rate. A lot of them will measure your heart rate, and they can be really handy and useful in picking up low heart rates or very high fast heart rates. That data is valuable, and it will hopefully empower you to do something about it. And most importantly, you take it to your doctor, and they'll diagnose you with whatever it may be. So it won't ever diagnose you with anything, but it's a cool, informative, real-time data that you have access to. Now more and more of them, including the Apple Watch, are detecting atrial fibrillation, which is a type of rhythm disorder, a heart disorder. The most recent study with the Apple Heart study in the US showed a fairly good detection rate, so they're getting better and better. But most importantly, it was that initial flag that took people to their clinicians for further investigation. So it was particularly beneficial in people over 65, who are more likely to have atrial fibrillation.
Okay.
So I wouldn't use it to diagnose all my conditions. I wouldn't get it for the diagnostic value of it, but it's really empowering to know.
So this is more sort of like an indication. You can't sort of put all your eggs in one basket with it, but it just starts a conversation in your awareness with these wearable technologies. So, thank you so much, Natalie. Another round of applause. So on the subject of the gym, so our next Together Tuesday will be on the first Tuesday of August. Does anyone want to guess what day?
Tuesday.
What date? Give me a number. No one wants to guess. It's 3rd of August. And so what we're going to have is Techno Gym coming and talking about how to do anytime, anywhere exercises, which will take your health, your lifespan into your health plan. And so it's about moving around, using the gym, little simple exercises, anytime, anywhere, any place, to actually increase your longevity. About small steps, small steps to get there, because that's really what it's about, everyday steps. The one thing I will disagree with you about is having a drink at the bar will help your longevity. So on that topic, thank you so much, everybody. Grab a drink from the bar, chat to everyone, let's have a conversation, because this community is amazing and wonderful. So please do open up to your friends, family, relatives, everybody else, because that's what we should be on, this same path together. So thank you so much.